Hello, everyone. We'll give folks just a few more seconds to join. Hope everyone's having a great evening. Give it till 8:01 and 30 seconds, so just a little bit longer.
That precise, huh?
Yeah. Unfortunately, I have my clock set to show the seconds.
Understood.
Yeah. Oh yeah, I think that was the right choice. We have some more people hopping in now.
Good.
Might push it till 8:02 just to be safe, and then we can get going then.
We'll start 8:01 and then we'll do slow introductions.
Yeah, that works too. All right, we can kind of kick things off now. Thanks everyone for hopping on. Hello everyone, and thank you for joining us for this evening's webinar. I am Eric Childress, the Client Services Manager here at JARALL Medical Management. Before we get started, there are a couple of housekeeping items I'd like to review with all of you. First, I will moderate a live Q&A at the end of this webinar. At any time, feel free to submit questions via the Q&A button, which should be at the top of your screen. Our speaker will address your questions during the live Q&A at the end. And second, this webinar will be recorded and emailed to all of you in the coming days. With that, the topic of this evening's webinar is the importance of proper documentation in E&M and procedural coding. I'm joined by Dr. Alan Bass, our presenter, and also the CEO and founder of JARALL Medical Management. I will now hand the webinar over to our founder. Dr. Bass?
Well, thanks, Eric. So let me do my little technical stuff here and let's see if we can get this up and running. And I'll ask you to tell me when you could still, first we'll do this. We'll click share. We'll do that. We'll go to PowerPoint. And
Gotcha.
we'll do slideshow. Good. We're all set?
Yes, sir.
All right. Well, thank you everybody for joining us this evening. What I try to do at least every third month, because we put these webinars on monthly, we're going to take a little break for the summer, is try to come up with an important topic that I think is beneficial to everybody. As much as E&M coding and procedural coding has been talked about over the last 5 years with its change back in 2021, I still get many questions on that. So I thought tonight was important. As Eric said, tonight's webinar is going to be recorded and sent to you. In addition, it's going to be on the JARALL Medical Management Knowledge Center. So please feel free to be able to go there. There's some other webinars there, some good information there. So why don't we just get started? Eric, if there's some really pertinent questions that you think would be relevant and stopping me mid webinar, please feel free. If not, we'll take, all the questions at the end.
Definitely, will do.
So tonight we're going to talk about a few different things. We're going to review the table that has been created for E&M coding. We're going to discuss proper coding level based on MDM or time, medical decision making or time. We're going to discuss certain buzzwords that auditors look for and some documentation that auditors look for, and understand using the coding for E&M and procedures. So this is available to everybody on the JARALL Medical Management website. Again, this was done by and put out by AMA and CPT. The CPT codes, just as a disclaimer, of course, is a registered trademark of the American Medical Association, and all rights is reserved by them. But E&M coding for many years, as we all remember, prior to 2021, was based on this complex review of systems that, as podiatrists, let's be honest, we didn't do most of those systems. And to be perfectly blunt, a lot of physicians didn't do them as well because they focused in the specialty that they're in. So back in, starting in 2020 and rolling out into 2021, when it launched, the AMA came out with the new guidelines for E&M coding based on medical decision making, and then in a few minutes we're going to talk about based on time. Now, what's important to know is there is no need any longer for those review of systems. Your E&M documentation can solely be based on medical decision making and or time that goes along with it. So even if you do document on time, you still need to have certain elements there, but the time involved may actually bring you to a higher level. And we'll talk about time and its concerns in a few minutes. When you're talking about medical decision making is broken down into 3 separate columns. You could see that there is the number and complexity of problems addressed, the amount or complexity of data to be reviewed or analyzed, and then the risk of complications and or morbidity or mortality when managing the patient. When deciding on E&M coding, you must qualify for 2 of the 3 columns in order to bill for that level of coding. So if by some chance you are dealing with a complexity of problem that is moderate and would put you at a level 4 coding, but neither the complexity of data nor the risk of complications go along with that, then you cannot bill a level 4 code and you must bill a level 3 code. And whether it's a new patient visit or an existing patient, that's how it works. And we're going to go through the categories of medical decision making and some buzzwords that go along with them. One of the things that I want to cover is we hear a lot as podiatrists and as specialists when we're talking about testing, what can we use as the bullet points in our office? So if we focus on level 3 coding and we look at category 1 tests and documents, people used to always ask me, well, I take and I order x-rays and I interpret those x-rays in my office. Can that meet under category 1 that I've actually used 2 separate elements under the middle column, amount and complexity of data, and under the category 1, if I both document that I've ordered an x-ray and I've actually reviewed and wrote the results of the x-ray, does that meet using 2 under category 1? And the answer is no. You can only use one of those bullets in order to use the complexity of data. So when it comes to that, it's important to know that you must use, 2 of them in order to have category 1, and you only have to meet one of those 2 categories, or category 2. So we'll break these down a little bit more. We'll break down probably the most important one is the complexity of the number and complexity of problems addressed. Let's talk a little bit about time and how time focuses on medical decision making. It's very, very simple. if you document a specific level, a specific amount of time, and we're going to focus on this again a little bit later on when we talk about what you do during a visit, you are more than welcome to use time to code and encounter. But the one thing that I do want you to remember is that in this day and age, unfortunately, we do have to be concerned with audits and insurance, and auditors surprisingly know how to tell time. And to use time for every patient is probably not ideal, because if you're billing out level 4 visits, which it's probably even easy to get to with medical decision making, but doing it based on time, you need to document for a new patient visit, you spend 45 minutes with them. Or even a level 4 visit on an existing patient, you need to spend 30 minutes with them. And think about 30 minutes for existing patients. If you see 16 patients, and if you see more than that, you're spending more than, you're seeing more than 16 patients. Well, 16 patients is an 8-hour day. And that does happen. That people will document time. When it comes to auditing, they look at your keystrokes, they look at how many patients were booked in a specific day. So you are able to use time for specific patients. You have complex patients, you have patients who come in who may have ulcerations, osteomyelitis. You might have patients that you're discussing surgery on. You might have difficult patients that you spend time on. Explaining things to patients, explaining things to caregivers. Using time is completely okay to do, but to pick and choose it is probably would be more wise, and to focus more on medical decision making is definitely more on how doctors are using it. When you're talking about prolonged services in the office or an outpatient setting, when documenting time, and a lot of times you'll see it's 55 minutes for existing patients and 75 minutes for new patients, you can at a minimum bill for, if you're billing for a level 5 visit, and for those of you who are treating those complex patients who need that time and might need an admission to the hospital, and you go over that time, you will then be adding in an additional code for prolonged services, which is 99417. And you'll see on the table at the bottom here, when talking about a new patient visit, you'll see that you would bill for a level 5. And then if it's between 75 and 89 minutes, you would bill one additional unit of 99417. And you could see as the time increases, you will add additional units of 99417. When talking about an existing patient, be 55 minutes, and then adding in the 99417 once you'll add each unit in once you exceed that 55 minutes. But unless you get to the time involved for a level 5 visit, you are not going to be billing for those prolonged services. So what's the number one thing that has changed? So with the creation of the new criteria for E&M coding based on MDM and time, documentation was made easier. What hasn't changed is your EHRs, your colleagues, lecturers, make everybody believe that you still need more documentation that's really needed. And that is not true. This will actually, the word should be lead. This will actually lead to note bloat. So what do I call note bloat? Note bloat is 4 pages of documentation that could have actually been done in a half a page. Auditors know that what you do. They've reviewed enough charts and they know what actually should be in an encounter based on diagnosis and how long, what medical decision making needs to be in it, or how much time would be required for it. So remember that correct, succinct documentation will always be better than documentation that doesn't need to be there for a specific patient. If a diagnosis code is not relevant to the treatment of the patient for that day, it does not need to and should not be placed in the list of diagnoses associated with the coding for that day. So if it doesn't have anything to do with it, you're more than welcome to document it in the encounter. You're more than welcome to have it in the past history of that patient. That's great. But if it doesn't have anything to do with that day's visit, please don't include it as a diagnosis associated with the E&M code, thinking that it's going to increase that level of coding. There's no more review of systems. There's no more documenting body systems that have nothing to do with the patient's complaint or the podiatrist's scope of practice. You're not going to do genitourinary exams. You're not going to do psychiatric exams. Your E&M coding is now based on specific words, and these words will be the ones that guide your coding level. That's really what it's about. So don't think that having documentation in that E&M that is irrelevant will help you, because it will not. So what are some important words that should be used when documenting a patient's condition? Meager or negligible or no medical decision making. And all of these words go along with a specific level of E&M coding. Stable, chronic. So if somebody has a stable, chronic condition, and a lot of what we do in podiatry can be stable and chronic, that will lead you to a specific level of coding. Acute, direct, well-defined. These are important words that when patients come in with specific complaints that come about quickly and are these well-defined, well-focused conditions, those are the words that you should be using, because these words are the ones that go hand in hand with the level of coding that you're going to do. Stable, acute. Acute, direct, well-defined, inpatient, or observation. For those of you who have hospital coding, your hospital-based coding goes hand in hand levels with your outpatient coding. And while tonight's focus is not on hospital-based inpatient or observation coding, they do go hand in hand, and the words and the documentation for that are the same. Chronic, worsening, or progressing. This will, of course, increase your level of coding. New problem, undiagnosed, potentially high risk. You have a new patient that comes in with something that was never diagnosed by anyone before, which could be a high risk, which will then increase your level of coding. Acute, unanticipated symptoms. That could be something that an existing patient comes back after prescribing a medication, whether oral, whether topical. It could be an unanticipated system after you gave somebody an injection. So again, it's about your documentation that's going to lead you to that proper coding level. Acute complex injury. Chronic severe problem. Acute or chronic problem with injury or risk to life and bodily function. Each one of these terms refers back to proper level of E&M coding. So if your EHR does not have this documentation associated with the E&M coding, these should be built into your E&M coding for your patients. It's important. And every one of these, if you look at this list, every one of them can be associated with a problem that we do. You know, talking about chronic severe, you could have somebody who's got a Charcot foot. You know, acute complex injury, somebody comes in with a trimalleolar fracture. So again, all of these things are problems that we see in our practice. So I wanted to now focus on that wording and how it focuses on the complexity, the number and complexity of problems addressed. So let's start right at the top with level 2. It's a self-limited or minor problem. Could be, an ingrown toenail that doesn't have a lot of problems with it. So again, remember that a patient's problems and the complexity is based on two things. It could be based on the subjective nature of the problem and your objective findings, and put it into the specific category that it's in. Moving on to level 3, 2 or more self-limited or minor problems. And then you'll see that each one of the bullets in level 3 and all the bullets going down are or. So it doesn't have to have all of them. It just should be one of them. So if the patient presents with 2 or more self-limited or minor problems, let's say plantar fasciitis and tinea pedis, okay? A stable chronic illness. They could have chronic osteomyelitis. Again, it's a chronic illness. An acute or uncomplicated illness or injury. A stable acute illness, or an acute uncomplicated illness or injury requiring hospital or observation level of care. Now, everybody thinks that when you're admitting a patient to the hospital, it automatically will boost them up to a level 5. It doesn't have to always be there. Remember, it has to be the complexity of problems, the data, and the risk of that patient. When bringing it up to level 4, 1 or more chronic illnesses with exacerbation, progression, or side effects of treatment. 2 or more stable chronic illnesses. 1 undiagnosed new problem with uncertain prognosis. 1 acute illness or systemic symptom. And an acute complicated injury. So again, it can be any one of those. And when getting down to level 5, we're talking about 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment, or 1 acute or chronic illness or injury that poses a threat to life or bodily function. So you can see that each one of these terms can go along with a diagnosis associated with it. So when it comes to time, and again, this is exactly the same. I just brought it back in there just for demonstration purposes. When it comes to time, it's all the time that relates to a patient care on a single day and only that day. The important thing to remember is that it's not only your face-to-face time with the patient. So if we go back to here and you see a patient that you ultimately decide they should be based on time, it could be a new patient that's being referred to you for a problem and you're reviewing medical records in labs. It could be an established patient that you had to call another referring provider. It can be reviewing labs. It can be doing care coordination. All of the time that you spent, and only you, so it's not your staff for that patient, it's only you, and it's the time you spend on that day only. If you review something the day before for a patient coming in, you can't use that for the amount of time that you spent with that patient. It's a whole list of things that can go on, but only if you do them that day. Labs, radiology reports, films, whatever it might be, but only on that day. Oh, so I have the list here. Preparing to see the patient. Obtaining and or reviewing separately obtained history. Performing a medically appropriate examination and or evaluation. So you can see the first two are not with the patient. Number 3 is in front of the patient. Counseling or educating the patient, family, or caregiver. It's all included. It's not, and it may not be face-to-face with the patient. You might go sit in your office and talk to a caregiver. Ordering medications, tests, procedures. You know, when talking about medications, please don't think that you're going to add in 10 minutes of time to prescribe, an oral anti-inflammatory. But if you're ordering multiple things and multiple tests and follow-up procedures, that's important. If you're spending time calling the hospital and setting up a procedure, that counts. Referring and communicating with other healthcare professionals when not separately reported. If it's reported on a separate consultation, that's not part of this. But if it's communicating with primary care, vascular, a dermatologist, I don't care who it is, that is now included in the amount of time. Your documentation, the amount of time you spend documenting that patient and doing your note for that patient. If it's a long, complicated case and you're spending 15, 20 minutes making sure you get it all in there, that's time. Independently interpreting results and communicating those results. So remember, if somebody comes in with x-rays with no report, if somebody comes in with an MRI or a CAT scan or a bone scan, whatever it might be, if you are independently interpreting the results, not reviewing results that were already done by someone else, like a radiologist, that could be included in time. Remember, if somebody had already had things like an MRI, a CT, x-rays done before, that was paid for previous to you. So it's not like you can bill with a modifier on the x-rays if they brought those in with a report. If they brought it in with a report, the part of the x-rays have been billed. But if you're independently reviewing films, that then goes under the E&M for that patient. As I said, care coordination, you're setting up home health care, VNA, whatever it might be for wound care at home. That's on part of the time. So let's say you document 105 minutes. You don't have to document the time spent on each and every one of these, but you should state what you actually did to account for the 105 minutes. So at the end of your note, time spent 105 minutes. This included, and we could just use the numbers, number 1, number 3, number 4, number 7, number 8. And of course, you should be spelling these things out because you're not going to say the numbers. I'm just using the numbers for demonstration purposes here. You should be writing all that out in the note. You're prepared to see the patient. You did your documentation. You ordered this, you ordered that, and that's what got up to 105 minutes. It doesn't need to be, you reviewed tests for 12 minutes and this, okay? So it's just a total time and what you did for that time. So let's talk about some documentation and what will pass an audit. So if I was giving this live and in person to people, I would actually be asking questions on whether or not does this pass an audit. I discussed all the options with the patient today, including indications for treatment, risks of treatment, potential complications, the expected outcome, and the patient understood. And I'm going to make believe I asked that to you all sitting in the audience, and some of you raised your hand and said, yes, that will pass an audit. And some of you said, no, that will not pass an audit. The answer to this question is no, this will not pass an audit. And why will this not pass an audit? Documentation should contain the specific options, the specific treatment, the specific risks, the specific complications. Not just you discussed all of them. Additionally, you can never state the patient understood. You are not in the patient's head and cannot document the patient understood what I told them. You can put in there and you can dictate and you can document that it appears the patient understands. Because that is the type of, those things will pass the audit. When you put in the specific options, the specific treatments, risks, complications, and that the patient appears to understand, that qualifies and will pass an audit. The management of E&M coding. So too many times, physicians think that the management in an E&M as a procedure, let's say it's somebody who came in with ingrown toenail, and you did a partial nail avulsion or a matrixectomy. When talking about management, you should think about management as a plan of care or medical management. So let's talk about the patient who has an ingrown toenail. Your plan of care is not the procedure. Your plan of care is not the matrixectomy or the nail avulsion. Your plan of care is discussing how the patient got an ingrown toenail, the options for treatment of an ingrown toenail, the risks of not doing a procedure for the ingrown toenail, the possibility of the problem coming back even after performing a procedure for an ingrown toenail. That is management. That is the discussion of what goes on. That is how you are going to manage your patient. The evaluation, the E, is your objective examination that you're documenting. But the management is the plan of care. Think about a plan of care like a physical therapist lays out your plan of care if you're sending your patient or you yourself personally went for physical therapy. Documentation of a plan should start with medical management of a chronic problem, ... That's how it should start. Or the plan of care, or I discussed the diagnosis with the patient, and then list everything about that diagnosis. The medical decision-making educational paragraph should be direct, explain all the info to the patient, and be something a colleague would read and say, yes, I get what this doctor was trying to do for you. So if that medical record was reviewed by someone else, there should be no ambiguity in what was done. That's all it should be. Make believe that somebody else is going to be reading your note. For the top problems you treat, make sure you address the documentation before audits and downcoding by insurance companies. So I'm going to implore all of you to go back into your EHRs and look at these top problems, whether it's an ingrown toenail, whether it's a neuroma, whether it's plantar fasciitis, whatever it might be, and think about it as it comes to a plan of care. I was having a conversation yesterday with one of my coders, and this is an important thing for everybody to realize. When documenting both an E&M and a procedure, I want you to think about it in this manner. If you think that you should be paid or reimbursed for both an evaluation and management and the procedure, you have to think about two things. Number one, remember that every CPT code has an element of an E&M built into it. Every procedure, whether it's in toenail avulsion, an injection, I don't care what it is, there is an element of an E&M built into every procedure we do. That's number one. Number two, when thinking about your documentation, think about your documentation. Can you take your encounter, your note for that day, if you're billing both an E&M and a procedure, can you divide it up into two completely separate freestanding notes and have each one of them stand on their own when it comes to coding? If they can't, then you can't bill for both of them. If you have documented properly for an E&M and a procedure on the same date, they should be able to stand on their own if you carve them up into two completely and parse them into two separate notes. A few things about E&M coding levels. When it comes to, now we're into the last column, into the third column. There is minimal risk of morbidity from additional diagnostic treatment. Is follow-up needed even? So if follow-up is as needed, this is probably more of a level 2 code. A level 3 code. There's a low risk of morbidity from additional diagnostic testing or treatment. Example, medication not requiring prescriptive authority and over-the-counter. Durable medical equipment, physical therapy, a consultation or referral. Those are things that are low risk and would more likely fit into a level 3 E&M code. A level 4, a moderate risk of morbidity from additional diagnostic testing or treatment. For example, prescription drug management, a decision regarding minor surgery, elective surgery with patient or procedure risk factors, or diagnosis or treatment impacted by social determinants of health. Now, we could have a completely separate lecture about social determinants of health, But that is something that is very important. So when we talk about, and we'll work backwards in this. So since we're on social determinants of health, you know, are patients taking medications properly? Are they picking up prescriptions? Are they not picking up prescriptions? They're not able to get to the doctor because they can't afford to. They don't have transportation. They don't have a caregiver to bring them. That's a social determinant of health. That's something that would bring it up to a level 4. When we talk about prescription drug management, writing for something, as simple as maybe a week's worth of a prescription might impact them based on their past medical history. So not every prescription brings it to a level 4 code, but based on a patient's past medical history, they sure as heck might get to a level 4 code. And a level 5, a high risk of morbidity from additional diagnostic testing or treatment, drug therapy requiring intensive monitoring, decision regarding elective major surgery, patient or procedure risk factors, emergency major surgery, taking the patient right to the OR, hospitalization or elevation. You took your patient from, you're billing for a level 4 code for a hospital visit, but now you had them, they took a turn for the worse and had to get admitted or upgraded to an ICU bed. Then that patient can be a level 5 code. You have patients that have all these problems. They have a DNR or get parenteral controlled substances. These can all be patients that qualify for a level 5 coding. So here is documentation, and I'm not going to read it all to you, that, in my opinion, this is documentation that will pass an audit for a nail matrixectomy. This has everything that they need. We talked about risks. We talked about the procedure. We talked about the treatment, the site, the benefits of the procedure, alternatives, and that the patient, if this happens to be a pediatric patient and the mom has elected to proceed. Because and remember, if you're seeing a patient and this is a minor patient and you just write the patient elected to proceed with the procedure, because that's how a lot of EHRs are set up, that's going to get you into trouble if this is a minor procedure. If a minor patient along with a minor procedure. This is some more documentation about that. Again, making sure everything about the procedure itself was discussed. So, if we take both the consent, and it doesn't even have to be the consent, we could have labeled that plan of care. If we take the plan of care in this case, along with your observations and your objective findings here, and add it to the documentation for the procedure, this will all pass an audit. But just this slide, along with your objective findings, will not pass for an E&M plus the procedure. You will only get credit, even if this is a new patient, for the procedure. Some more documentation when it comes to denials for same and similar, because this is now the new thing. And while you should all have access to the DME portals and sign up for the DME portals to know whether or not you gave somebody a piece of durable medical equipment that is same within the last 5 years, some of you don't, and if it gets denied, here is some documentation that will assist you in passing a denial for a same and similar DME. When talking about ultrasounds, this is the information that should be there when discussing and proceeding with an ultrasound in order to pass an audit and to not be denied. So I want to thank you for listening to all of that. I am hoping that some of this sparked some questions in your brain, and I'm going to ask, and even if it didn't, if you're embarrassed and don't want to ask a question, feel free to email me, and I'll be more than happy to answer any questions that you have. So, Eric, by some chance, did anybody pop any questions in this evening?
Yes, sir. We had one come in earlier, but I think a slide after that answered that question.
Well,
But we did have one
let's
come in
recap
through.
it.
Oh, yeah, sure, of course, of course. The question was, can you give some specific podiatric clinical examples of these terms and levels of MDM? So that was back when you were on the, oh, please.
Was I on the
Was
table?
when you were on the important words slide. That was slide 7.
Okay, so tell me if I get back to, where am I at? Let's go back and tell me, get all my arrows out of the
Just
way and,
before this. Yep, right here, right here.
okay. So again, some of these examples, there's really nothing special about this. When, if we talk about no medical decision making, this is a patient who might have been following up for several weeks for an ankle sprain and really had nothing specific going on that needed to be dealt with. Um, a stable chronic issue like somebody coming in for a bunion, follow up for, maybe first MPJ pain. If we're talking about chronic, worsening or progressing, that could also be a bunion that is getting worse. A new problem that is undiagnosed, potentially with a high risk, that could be somebody who comes in with an ankle sprain and do a draw test on them and you think that they may have, a soft tissue injury that needs further diagnostic treatment. These are the different things that go along there. Um, I think I said during an acute complex injury, somebody could come in with a Lisfrank's fracture or a trimalleolar fracture, chronic severe problem, chronic osteomyelitis. So these are all different things that patients can have that are important to use this terminology ahead of what the diagnosis is. I hope that answers the question. Eric?
I think so, for sure. Next question. When addressing using an E&M on the same day as a procedure, does an NP, not new problem, fit into this type of encounter?
So we're talking, that's really an incident two type of question. So the billing is a little different there, um, because the billing for the NP and the billing for the procedure, I'm not sure if they're asking, can the NP bill for both, or if the NP does a portion of it and you do a portion of it. Um, So, Eric, if you can just get me that person's email address, or that person, I'm going to address that to them directly. But
For sure.
normally, when I'm talking about this is things that you, as the physician, do, because not every state. When I practiced in New Jersey, I couldn't oversee a nurse practitioner, so that couldn't even happen in my office. So I'll communicate directly with this patient, and we'll get that question answered.
Definitely, for sure.
Any other questions?
Oh, yeah, just had one pop in. Does the new patient automatically give you a new patient E&M if you're doing a procedure, for example, nail care?
So the answer is yes. The answer is no. So I'm going to answer it both ways. Yes, it can be yes if, for instance, somebody comes in with onychomycosis and you're going to be doing nail care. If in the E&M you have the discussion on the plan of care with the causes of onychomycosis, the risks of not treating the onychomycosis, for confirmatory diagnosis, we should be doing a nail biopsy. We could talk about oral medication, topical medication, and all of that, in addition to your objective findings of that exam, is the evaluation and management, but then also performing the documentation. Performing the nail debridement if the patient complains of pain, or in the case of patients who are at risk. As long as you're following, the LCDs and the proper documentation, I see no problem with a new patient with onychomycosis and doing nail care cannot qualify for an E&M and the nail debridement. But if you don't go through the proper documentation, so that was the yes. The no is if you don't go through that whole plan of care with that patient, then you're not going to get an E&M out of that. You're only going to get your nail debridement. So I hope that answers that person's question.
Awesome.
And again, I'm going to just go all the way to the end and put my email address back up so everybody again will see it at the end. So again, if anybody feels they want to just send me an email about some questions, they can please feel free to do so as well. Any other questions?
Awesome. Yes, clarification on the question I asked earlier, and then we have another one after this as well. So I'm going to reread this. So when addressing using an E&M on the same day as a procedure, does a new patient, not new problem, fit into this type of encounter?
Whether or not the patient are existing is really irrelevant right now. I think I just want to make sure everybody understands that performing a procedure is not the management. Think about, you actually have to have three separate elements. You have to have the evaluation, which is your objective findings, the plan of care or the management for that diagnosis that you're coming up with, and then whatever procedure you do. Let's take another example. Let's talk about an aroma. You're going to do your entire objective examination on that patient. Your diagnosis is neuroma. Your plan of care, your M, your management of that E&M is everything about an aroma. How they got it, how you're going to treat it, what's the risks of not treating it, what's the proper shoe gear they should be using, what are the surgical alternatives, what are the conservative treatments you're going to do. That's under the management. That's the E and the M. And then the procedure is the injection. And you're going to document everything about that injection. What's in the injection, where it was given, how the patient tolerated the injection. Everything about that injection should be there as well. So I think that broadly covers everything about whether it's a new patient or an existing patient. You need the objective findings, the plan of care or the management, and then the documentation of the procedure.
Awesome. Thank you. Two more. If a new patient comes in for at-risk foot care, but also manifests other issues like ankle swelling, tenderness of ankles or heels, or gait difficulties, etc., how would that impact the E&M level if you do things like refer for PT or applying a strapping, etc.?
So so the new patient who presents with multiple problems will, again, when talking about the proper types of problems they have, where do they fit in? Is it an acute problem? Is it a chronic problem? Is it a stable problem? Now, talking about strapping, that's a procedure, as opposed to a referral, that's something else. So we're talking about two different things. So it's wherever those people come in, where they fall. So now, in this case, you said that this patient was coming in for at-risk foot care, but then had other problems. Again, addressing those individual problems under your plan of care is what's important here. If it's ankle pain in addition to the at-risk foot care and you're sending them for PT, discuss what should be going on at PT. If it's swelling, and what are the risks of swelling, and what do you think can happen, and why you're sending them maybe to the vascular doctor, or why you might suggest doing a vascular exam in your office. It's all about what you document. It all comes down to documentation. And think about each problem individually. Think about maybe it's an ankle problem. Think about an edematous problem. Think about at-risk foot care. All these different things. Think about them separately under that plan of care. And then document whatever you do. And that can qualify for both the E&M and the procedure.
Thank you. One more. If you use the LEAP protocol, what level of E&M would be appropriate in that scenario? And I know that's kind of tying too, but you know.
So for those of you who are not familiar, there is a program out there now. I don't know if that's through Arch or through other programs, but using any program that ensures proper documentation or causes you to have a certain level of medical decision making, it's all based on what you did. So for instance, if you're evaluating dry skin, if you're evaluating neuropathy, if you are doing something that would cause you to change your protocol at a specific visit for something that you have found, then that would qualify you for an E&M, or a change in E&M, or an increase in E&M. So if that patient was just coming in for at-risk foot care and you went through any one of these different documentation programs, you might be able to bill for that E&M, and whether or not you're doing a procedure. If you are at a specific E&M level from one visit and the patient comes in and something has changed, it might cause you to be able to bill for another E&M or an increased level of E&M. It all depends on your findings.
Thank you. I think that was our last question.
All
Unless
right.
we have any more.
Well, we are coming to the top of the hour anyway, so I again want to thank everybody for attending. And if anybody has any questions about that they want to email me, please feel free to email me. I know Eric said this will be emailed to each and every one of you. And then you will also be able to find this. It will be posted on the JARALL Medical Management website in the Knowledge Center. So with that, I want to thank you, Eric, for assisting this evening. I want to thank all of our attendees. And I guess with that, we will be adjourned. Thank you very much, everybody. Have a great evening.
Good night.
Good night.